This program is brought to you by Emory University.
Good morning. It's really a great honor for me to have the opportunity to introduce today our speaker for our cardiovascular grand rounds. Dr. Wenger's distinguished career and distinguished achievements are synonymous with the history and the future of cardiology. Her commitment to women's health and disease and her passion for service to patients, research, education, and mentorship are unmatchable. Dr. Wenger has chaired the U.S. National Heart, Lung, and Blood Institute Conference on Cardiovascular Health and Disease in Women. She has chaired the World Health Organization Expert Committee on Rehabilitation After Cardiovascular Disease, and she co-chaired the Guideline Panel on Cardiac Rehabilitation for the U.S. Agency for Health Care Policy and Research. She has received multiple local, national, and international awards, including the Gold Heart Award, which is the highest award given by the American Heart Association. She has been the chair of multiple writing groups for guidelines. And today, Dr. Wenger will talk to us about juggling multiple guidelines and how to find the balance in the woman's heart. Dr. Wenger, without further to say, it was a pleasure, it's an honor for me.
Good morning. We will be talking this morning about prevention of cardiovascular disease in women. But what we're faced with today is a multiplicity of guidelines, hence my title of How You Juggle Multiple Guidelines, particularly when a woman's heart is in the balance. And some of our discussion, I think, can be a roadmap for what we do as serial guidelines appear and how we manage these in clinical practice, in discussions with our colleagues, and in discussions with our patients. These are my disclosures. And let me start with what is now really past history, and that is the 2011 update on the effectiveness-based guidelines for the prevention of cardiovascular disease in women. And of course, this is the last update that we have on the topic, and it's amazing for us to sit here and say 2011 is past history, and so many things have happened then that many of the recommendations in this static guideline are outdated. Remember that when a guideline comes out in 2011, probably the last of the data included are those from 2010. So what do you do when you have this guideline? This essentially recommends what we ought to do for prevention of cardiovascular disease in women, and where do we go from here? What I plan to do is to tackle the specific items within the guideline, to tell you, in a sense, how some of them have changed, to let each of you think for a minute, what do you do or what should you do in your daily practice? And then I'll let you know what I do and why. One of the prominent features of the 2011 update to the prevention guideline was the classification of cardiovascular risk for women. And this was difficult because at that time, not that long ago, 2011, there was a high lifetime risk for cardiovascular disease in women. On average, 1 in 2 women died of cardiovascular disease in her lifetime. And just until now, until 2015, that has changed. It's now 1 in 3, and in some reports, even 1 in 4. So mortality for women has plummeted in the last few years. But when we look at the clinical trial data that underlie the guidelines, we all know that women have been underrepresented in clinical trials, but those where they have been represented involved either high-risk women, women with established cardiovascular disease, or apparently healthy women. And there was really nothing in the literature to help guide what we would do for women who were at intermediate risk. And then at that time, there were major limitations in the standard risk stratification approach, particularly the Framingham risk score. First, it addressed only short-term risk, 10-year risk. And we all know that women develop their heart disease later in life. So 10-year risk really is not adequate. And then a great deal of data were emerging showing that there was a high prevalence of subclinical disease, whether it was by coronary calcium or carotid IMT, in women who were identified as being low risk by the Framingham risk score. So we were not happy with the Framingham risk score, and I think most of us realize that Framingham unquestionably underestimates risk for women, both because of its scope and because of the 10-year risk. What we did then in this guideline is to identify 3 groups which we thought would be helpful for the clinician. And high-risk status, and that's a woman who has at least one high-risk manifestation, myocardial infarction, stroke, peripheral vascular disease, etc., or more than a 10% 10-year risk per Framingham for all cardiovascular events, realizing that we can't focus solely on coronary heart disease because a woman's risk for stroke and heart failure, indeed at most times, is greater than her risk for stroke. So we have the high-risk women. And then we identified a population as being at risk, and I will show you those variables in a moment. And that is essentially a woman who has any risk factor. And then the third group we identified was the group of ideal cardiovascular health, and that is the woman who, without therapy, has no history of smoking, normal weight, normal blood pressure, normal cholesterol, good physical activity level. And surprisingly, that is far less than 10% of our total population, sadly. Then what happened? Just 2 years later, this report came out from the American College of Cardiology, American Heart Association, with lots of people signing on, and that's the guideline for the assessment of cardiovascular risk. And I think that we have to accept that because this now involves many more trials as a basis for the assessment of risk, many more contemporary trials on contemporary therapies, that this should surpass the guideline that we did in 2011. And what do we hear from this guideline on the assessment of cardiovascular risk? Certainly, does the patient have clinical atherosclerotic cardiovascular disease? And as a matter of fact, this part is gender neutral. Then you look at guidelines for secondary prevention. This risk addresses patients between 20 and 79 years of age. So there's a separate pediatric guideline, and there are just precious few data above age 79, which is the limitation for our clinical practice. And then the emphasis is on using the pooled cohort equations. Some love them, some hate them, and I will talk about them in a minute. But that is the new emphasis on the assessment of cardiovascular risk. And then from those, you can identify the individuals at low risk, and then you check the risk factors at longer intervals and recommend lifestyle interventions. And I expect that that is what most of us do today in our clinical practice. And this is the risk estimator that's on all of our handhelds. And this, of course, is gender specific. Now, it's not meant to be used for individuals who have disease. It's not meant to be used for individuals who have a very high, greater than 190 milligrams per deciliter primary elevation of LDL cholesterol. But what you do to compute this risk is you do gender, so this is very gender specific. You identify the total cholesterol, the HDL, whether or not there is treatment for hypertension, whether or not the individual is a smoker. Remember, I told you the age where this is useful, because these are the only data available to compute risk, are between 20 and 79 years of age. And this is also race-specific. There are powerful data for whites and powerful data for African Americans. The other are less powerful because there is a fairly small representation of Hispanics and of Asians in the trial populations that form the basis for this guideline. And the emphasis here on systolic blood pressure, which you define between 90 and 200, and diabetes. So this is a very simple risk calculator. And again, how should we use it? When it first came out, there were several reports, some of them not well thought out, and some of them not in correct populations, that said this overestimated the risk for women, this underestimated the risk for women. And then as the smoke cleared, it came that it really is quite good. It probably will be tweaked a little bit as more clinical trials are added to the basis for this. But we have a paper in press looking at this in the very large Women's Health Initiative, which looks at older women. Paper is in publication. And again, very good data collected longitudinally in a contemporary population with very good validated outcome data. And this performs quite well. Not so sure how well it performs in the younger women, and some of this may be that the younger women in this country are a changing population. Early on, they were at lower risk, but now, as we see from the Virgo trial and from other studies, we're seeing increased cardiovascular risk among young women, likely in great part related to the epidemic of obesity, of sedentary lifestyle, and of consequent diabetes. So some of this may indeed be a moving target. Now, this was the classification that we used in the 2011 guidelines in terms of classification for risk. And I think we have to think of all of these. The smoking is in the new risk equations, blood pressure, total cholesterol, obesity, diet, physical inactivity. Family history does not occur in the new risk equations, nor does metabolic syndrome. But one of the things that we have to think about as we see patients in our office, because many of them come to us with test data, is that some of the women that we see have evidence of advanced subclinical atherosclerosis. They have coronary calcium, they may have a carotid plaque, they may have a thickened carotid IMT, or they have poor exercise capacity on treadmill testing. And we've come to realize that indeed, both for women and for men, an exercise capacity of less than 4 or 5 METs is a predictor not only of cardiovascular, but of total mortality. But 2 new things came up in the 2011 guideline that were not addressed at all in the risk equations, and I think are either specific to women or predominant in women, and that we must keep to the forefront. First is that the women who have systemic autoimmune collagen vascular disease, particularly lupus or rheumatoid arthritis, were identified as a population at elevated atherosclerotic cardiovascular disease risk. And then a very new emphasis, but one that has grown exponentially over the last 4 or 5 years, is that a history of preeclampsia, gestational diabetes, or pregnancy-induced hypertension is a very important issue, and as far as I know, it remains specific to women. Now, let me address the pregnancy complications, and the one message I want you to take away from this is that a detailed pregnancy history is an integral component of risk assessment for women. Now, what is it that we have on most of our databases? The number of pregnancies and the number of live births. And that is an incomplete bit of information, because what we have learned from many, many studies, and I've just cited a few of them below, is that the woman who has during her pregnancy preeclampsia, gestational diabetes, pregnancy-induced hypertension, preterm delivery, or indeed an infant who is small for gestational age, All of these are early indicators of an increase in cardiovascular risk. Now, it's often been said that pregnancy is the first stress test that a woman undergoes, and it is likely that the cardiovascular and metabolic stresses of pregnancy really have the potential for early prediction of future cardiovascular risk. I don't think these complications cause the risk, but it is quite likely that there are shared risk factors for the development of preeclampsia, for the development of cardiovascular disease. And let me give you some of the numbers. Preeclampsia and gestational diabetes in some of the studies below, a 3 to 6-fold increase in subsequent hypertension, at least a 2-fold increase in ischemic heart disease and stroke. And these are greater, for example, than the risk that's imposed by cigarette smoking, which we always check for. Now, in earlier years, it was thought that since preeclampsia, for example, terminates with delivery of the placenta, that the problem is over. And what has been seen and increasingly documented is no, there is residual endothelial dysfunction, and now in a number of imaging studies, it has been associated with an increase in coronary artery calcium, which most of us equate with atherosclerosis. Not surprisingly, the woman who has gestational diabetes has a 7-fold increase in the risk of subsequently developing type 2 diabetes. So this has to be very prominent on our radar screen. And then in terms of systemic autoimmune diseases, they are highly prevalent in women, and indeed, no one has yet explained why the systemic autoimmune diseases are more prevalent in women than in men. It is the subject of very active investigation. But there is an increase of coronary disease, an increase of cerebrovascular disease in the woman with systemic autoimmune collagen vascular disorders, not that well studied in men because there are fewer men with collagen vascular disorders. And indeed, if your woman patient has systemic lupus erythematosus, coronary disease is the major cause of morbidity and mortality. In the woman with rheumatoid arthritis, she has a 2 to 3-fold increased risk for myocardial infarction and for cardiovascular mortality. And more recently, this has been described with psoriasis and psoriatic arthritis, which increase the risk of cardiovascular events, but not in the studies done of cardiovascular mortality. The message is very simple, that women with these diseases warrant earlier and increased screening for the conventional coronary risk factors. So, given these data, I want you to think for a moment, what do you do as you screen the women for cardiovascular risk? Most of us use the new pooled cohort equations, and I think we should, and I do that as well. But these are the 2 other variables that I consider very strongly, and that is a pregnancy history, and I get that as part of the screening, and a history of systemic autoimmune disease. So both of these, I think, are very important, and they are part of the 2011 guideline. All right, let's go on then. I think we're in agreement that we extend the pooled cohort equations in our risk assessment of women, and indeed that's what we are doing in our Emory Women's Prevention Program. That is included in our risk panel. Now let's go back to the 2011 update. And the guidelines for preventing cardiovascular disease in women back in 2011 had 3 major subsets. They involved lifestyle interventions, they involved major risk factor interventions, and they involve preventive drug interventions. And let me just show you how I modify some of these in my clinical practice. In the 2011, we had fairly detailed physical activity recommendations for women, and these all had a class 1 and level of evidence B, so that there was a strong basis for these. And they don't differ much from what's recommended today. but 150 minutes of moderate exercise or 75 minutes of vigorous exercise or a combination of these, aerobic activity in episodes of at least 10 minutes, preferably spread throughout the week. And then the emphasis here was that additional cardiovascular benefit are provided by increasing the duration of moderate intensity or vigorous intensity or a combination of them. So this was one of the cases where there is fairly good evidence in women that more is better. And then there was evidence for muscle strengthening activities, essentially isometric activities that involve all major muscle groups, recommended twice a week. And then a specific recommendation that women who use physical activity either as a mechanism for weight loss or to sustain weight loss need more exercise than above. I find that this amount of detail is valuable for the women that I counsel rather than simply saying exercise, because it incorporates the time, the duration, the relation to weight change, and particularly the importance for strengthening exercise. Now, what do we have from our 2013 guidelines for the AHA and the ACC? Here we have lifestyle management, but it is only addressed at two goals. It is addressed at the goal of blood pressure control, and it is addressed at the goal of cholesterol management. It is not a global recommendation. So here we have, interestingly, the same recommendation for LDL cholesterol, LDL and non-HDL cholesterol, and for blood pressure, and that is for all adults without specific data for women. 3 or 4 sessions a week, on average 40 minutes, moderate to vigorous intensity physical activity, as a mechanism both for LDL and for blood pressure control. Certainly these are good recommendations. They are well supported by data. But what I do in my practice is I combine both, because I find that the women that I counsel appreciate more the detail, the type of activity, and really the information from the 2011 guidelines supplements this. Remember, this is directed, and the data in this guideline are directed only for blood pressure and for lipid control. Now, blood pressure. And I think this is an issue that has generated more heat than light over time. When we did our recommendations in 2011, we considered an optimal blood pressure being less than 120/80 millimeters of mercury, encouraged through weight control, physical activity, alcohol moderation, sodium restriction, increased consumption of fruits, vegetables, and low-fat dairy products, basically lifestyle. And we had very different recommendations in terms of what is to be done with pharmacotherapy. Now, you've all seen just a plethora of guidelines looking at the same data, but each of the groups who came out with a guideline chose different data points, chose different studies, and what we have today, I think, is likely confusion. And the only statement that is endorsed by all of the groups, the American Heart Association, American College of Cardiology, Society of Hypertension, relates to patients with coronary disease, has nothing to do with healthy people. And for patients with coronary disease, this group recommends a target of less than 140/80 as reasonable for secondary prevention in patients with hypertension. That's a 2A with a level of evidence B, moderately good. And then lower may be appropriate for some individuals, like higher risk ones. That's a class 2B, meaning that the evidence has just poked up a little bit through the lack of evidence line. And then, of course, we have the data that came out in the public press even more prominently than in the medical press, and that's the data from the NIH's SPRINT trial. And SPRINT, as you know, was a sizable population, but they didn't have that much baseline disease. They had hypertension. And the difference was treating to a goal of less than 140 millimeters of mercury systolic or less than 120 millimeters of mercury systolic. and the trial was stopped prematurely. Emory was one of the sites for the trial. The trial was stopped prematurely because of benefit in cardiovascular events and cardiovascular mortality. Now, paper has not been published, the detailed data analyses have not been done, but the trial was stopped prematurely because it was not considered ethical to continue to have a group treated to just the less than 140. So here we have back to where we started almost. And let me give you a few more bits of information that I think relate in part to women. I think when we look at epidemiologic data, and epidemiologic data obviously don't address intervention, but if you look at community data, that there is an increase in cardiovascular morbidity and mortality incrementally with any blood pressure level that is greater than 120/80. And specifically to women, in the Women's Health Initiative, Judy Shaw has a very nice paper where she compared the women with hypertension, with pre-hypertension, and who were normotensive. And the cardiovascular events with pre-hypertension were intermediate between those with normal blood pressure and those with defined hypertension. And that's a followed population of women, granted older women. Now, I want you to think, what is it that you do in your clinical practice? What are you going to do when you go to clinic this morning or this afternoon? And I will tell you what I do and have done and will continue to do unless data change. And that is, I think 120/80 is an ideal blood pressure goal in general. But I am quite careful in my older women to check them for orthostasis. And if they are orthostatic, certainly I think that goal is inappropriate. I think it's appropriate for patients who remain asymptomatic at that level of blood pressure. But if there is weakness, lightheadedness, or dizziness, I simply ease up on the antihypertensive therapy. But again, if this is a tolerated level of blood pressure, if this is not an individual who is at risk of dehydration, orthostasis, etc., and I have some worry about the diabetic patients. The diabetic patients were not included in the SPRINT trial. Then I ease up on the blood pressure control. But at the moment, I think 120/80 is a not unreasonable blood pressure for all the women that I see in my clinical practice. Now, lipids. And again, this was controversy 2013. And I think controversy 2013 has quieted down a bit for people who finally read the guideline rather than reading the headlines about the guideline. This goes back to our 2011. And I'm not going through the numbers, but we basically wanted an LDL below 100. We liked elevated HDL, but as you know, there has not been a therapy that safely can increase HDL to date. And triglycerides, I think, have fallen out of favor, except for the concern with a markedly elevated triglyceride that raises the risk for pancreatitis. And what we recommended, this was back in 2011, is that for high-risk women, certainly lifestyle first, but combining lifestyle with pharmacotherapy for the individuals who were at high risk. And that was the time that the trials came out in the setting of acute coronary syndrome, showing benefit of an LDL below 70. And with a class 2A recommendation, we said that that is reasonable for very high-risk women, such as those with a recent acute coronary syndrome or poorly controlled risk factors. But then we had 2013. And of course, the guideline panel, and I think what they did was to say, what is it that the evidence shows? I think certainly the evidence focused on LDL cholesterol. They did not address HDL because there was no effective HDL-raising drug. They did not address triglycerides, again, save for the very high triglyceride that might put you at risk for pancreatitis. But they said LDL therapy is what should be addressed. And importantly, they said that there was no evidence of LDL goal. Now, go back to the clinical trials. The clinical trials were high-dose versus low-dose medications. They were thought to reach various goals, but absolutely none of the trials titrated medication to goal. And therefore, the guideline panel said we shouldn't have any LDL goals, and that all of this should be based on cardiovascular risk. And we go back to the pooled cohort equations, and individuals who were at high risk should be treated with a high-intensity statin, individuals who were at intermediate risk with a moderate-intensity statin. The presumption was that a high-intensity statin would reduce LDL by 50%, and a moderate-intensity statin would reduce LDL by 30 to 50%. And we were told not to measure LDL, except to assess adherence. So it didn't say don't measure LDL. It said measure it to assess adherence, and then gave you the option that if there was not the desired effect and you thought your patient was adherent and the LDL goal of 50% or 30 to 50% reduction was not obtained, then you could consider getting a more potent statin or adding a second agent. Now, at the time these 2013 guidelines came out, there were a lot of medications that were not on the scene, and we have them now. The IMPROVE-IT trial showed us that the addition of ezetimibe substantially lowered LDL, but the most important thing, what we look at is not just the number lowering, we're looking at outcome events, but that was associated with a favorable effect on outcome events. Now, IMPROVE-IT had to go for about 8 years or so until they enrolled people and got that outcome. But nonetheless, here is the addition of ezetimibe to a statin, which is a preferred drug on these guidelines, and it did reduce cardiovascular events. And then, of course, within the last few months, we've had the advent of two drugs that act by a totally different mechanism, the PCSK9 inhibitors, that lower LDL levels markedly. And we have no clinical outcome data, no clinical trials on the PCSK9. They were approved by the FDA for lipid lowering because it was so prominent. In the few trials that were done, they were not sizable clinical trials. They did show benefit. They had very favorable side effect profiles. That is the most impressive. The downside is that they are enormously expensive. They're injectable drugs. They're given either twice a month or once a month by injection. But the fascinating feature of these PCSK9 drugs is that they have virtually no unwanted effects. And the biology behind that is that the PCSK9 receptors seem exclusively in the hepatocytes. They are not found or have been documented to be anywhere else in the human system. And therefore, we should expect a favorable adverse effect profile for them. But I think this is going to be a learning curve as they are used in specific patients, and it will probably be 2017, 2018 until the several clinical trials that are in progress are reported out. But now we have evidence that LDL levels ambient on these medications, as low as 20, 30, 40, have not been associated with any adverse effects. And the question is going to remain, how low do you go? Well, what do I do with my women patients? And actually, I don't think it differs very much for women and for men, except that the women should not take statins during a pregnancy. But I think that the guidelines that I have up here for you are reasonable, using a high-intensity statin for high-risk patients and a moderate intensity otherwise. But I have 3 or 4 problems with this, and I'll tell you how I address the problems. The first is that the high-intensity statin is not recommended over 75 years of age. Not that it's been shown to be harm, but there's no data for men or women over age 75. Now, if a patient has tolerated a high-intensity statin to age 75, I don't say this is your 75th birthday, change the statin, and I keep them on the medication. But we have to realize that with aging, there is a change in statin metabolism so that the dose may be somewhat higher, and I watch. What about the woman who has an acute coronary episode in her 70s? I basically use the high-intensity statin because I think that during and shortly after, this is a period of very high risk, and if she has tolerated the high-intensity statin in hospital, I will continue it. So that's the older end of the spectrum. Now, what about the younger women? We're now beginning to see myocardial infarction in women younger than age 40. We saw a sizable representation of them in the Virgo trial. We're seeing a sizable burden of risk factors before age 40, which is where we're told to start measuring. And I think for the women that are at high risk clinically, the complications of pregnancy, the autoimmune disease, the diabetic women, etc., I measure their lipids and I treat them fairly intensively, depending on what their risk level is. I don't wait to age 40, because by that time, again, based on data from the Virgo trial, many of the women will have had a major coronary event. So it's at both ends of the spectrum that we have to get more data, and I urge you to be alert for more studies that come out. Virgo is still doing some sub-analyses on lipids and so forth, and we will have more information. But this is the way I behave in my clinical practice. And these are the guidelines for the treatment of blood cholesterol. I've just highlighted some of the features for you, saying that it really depends on the level of risk. You've all seen these. And again, the emphasis in the bottom corner is that there should be, if I can get this pointer to work, yeah, there should be a detailed discussion between the provider and the patient as to the risks and benefits of statin therapy, and this becomes the shared decision-making for the women who use this for primary prevention and who are not at high risk, identifying the benefits, identifying the risks, and identifying that per the guidelines, statins are the chosen medications, that a lot of the others that our patients really like do not have good enough evidence for prevention, and many of them do have adverse effects. And again, just the fact that I do measure LDL. I measure LDL to assess adherence, and I think, if I had to guess, over the next couple of years, we're going to see some change in the guidelines, and we're going to see some guidance about levels. CMS, the Center for Medicare Services, has asked the guideline panel for some guidance on ideal levels of LDL because they want to use this to guide recommendations for these new PCSK9 inhibitors. And if you think of patients, the behaviorists say that it's patient behavior that's as important as any of the discussions that we have and any of the drugs we prescribe. And patients like goals. We have goals for physical activity, we have goals for weight, we have goals for blood pressure, we have goals for everything. Why is LDL the orphan without a goal? And I think patients probably would do better with a specific goal. So with some queries from the behavioral and patient community and queries from CMS, I would guess, and it's purely a guess, that we're likely to get a little bit of guidance with an LDL goal. And then patients ask me, as they ask you, what should my LDL be? And I say, this is the evidence that we have, that in the patients below 100 did better, that in the setting of acute coronary syndrome, below 70, they did better. And now we're beginning to get evidence that you can get LDL quite low and without harm. So this is a stay tuned. And just to summarize for you, to pull out of those elaborate tables, the 4 groups of patients where there is major statin benefit are obviously the patients who have clinical manifestations of atherosclerotic cardiovascular disease, those with primary elevations of LDL greater than 190, and this is the group likely that has some familial hyperlipidemia. Then individuals 40 to 75 years of age with diabetes and an LDL between 70 and 189, now it's lower, without clinical disease. And then the group where we have most of our discussions is your patients, and for this purpose I'm addressing the women, without clinical disease, without diabetes, 40 to 75, LDL between 70 and 189, 10-year risk of 7.5, just intermediate. And here's where you and I discuss this with our patients, men and women. Now, back again to the 2011 guidelines. There were class 3 interventions that were not useful and effective and actually might be harmful. And those were menopausal hormone therapy and antioxidant supplements, and I think those recommendations remain. And if your patients are like mine, it is so hard to get the women to stop the antioxidant vitamins. They just love them. There is not evidence for harm from the antioxidant vitamins, but they are taken in preference to other medications that produce benefit. On the other hand, folic acid with and without B vitamin supplementation has been shown to produce harm. And again, this is not folic acid used to prevent problems during pregnancy. And then I just want to give you one example of medication differences, and that's aspirin. Aspirin is not recommended to prevent myocardial infarction in women under age 75. Totally different spectrum. In men, in the Physician's Health Study, aspirin, and that aspirin was at a dose of 100 milligrams every other day, which was the medication dosage at the time the trials were started, prevented MI and not stroke. In women, it prevents stroke, but not MI. Now, what else is new? I'm going to go through this briefly because Dr. Lundberg is going to discuss this in detail next week. But we have new guidelines for the prevention of stroke in women, and this is a chart with which you should be familiar, and we need to incorporate this into our electronic medical records, because what we have here that is very valuable for our clinical practice is sex-specific risk factors stronger or more prevalent in women, and those where either they're the same or we have no data. We've already addressed the issue of pregnancy, preeclampsia, gestational diabetes, but oral contraceptive use increases the risk for stroke, menopausal hormone therapy, and changes in menopausal status. So this goes into our risk assessment. And then the factors that are more prevalent in women, migraine with an aura, atrial fibrillation, diabetes, hypertension, and depression and psychosocial stress. So these are new. This is a new guideline. This gives us help in preventing stroke as an endpoint, and I follow this guideline, and I think we have to incorporate this into our medical records. Now, another feature that has not been adequately addressed is depression, and the data are strongest in the acute coronary syndrome. This is a recent statement from the American Heart Association, and the conclusion is that even though there is heterogeneity in the published studies, and interventions have not been generally effective, depression should be elevated to the status of a risk factor in patients with an acute coronary syndrome. We know that women have more depression than do men. We know that depression is a risk factor for the occurrence of acute coronary syndromes, more prominent in women than in men, and some of that work has been done in this institution. And we really should be checking for depression with the 2 standard questions that all of us have learned, and that also needs to go into our electronic medical record, and I do that. Finally, again, new for women is the role of non-invasive testing in the clinical evaluation of women with suspected ischemic heart disease. My conflict is that I'm an author on this, as is Leslie Shaw from our institution, and basically what is under consideration is the initial diagnostic procedure of women who have symptoms and are suspected to have stable ischemic heart disease. Based on age, women are categorized as low, intermediate, and high risk, but when there is extensive comorbidity and multiple risk factors and functional disability defined as a MET level below 4 or 5, that increases the risk category by 1. But important is that women who are at low risk are generally not candidates for further diagnostic testing, and it is in this group that we should be looking for a non-stable ischemic heart disease etiology of their symptoms. For low to intermediate risk, the basic recommended test is a treadmill, ECG, if the woman is functionally capable of exercising and if she has an interpretable resting electrocardiogram. Once you have intermediate to high risk, either by age or the multiple comorbidities, stress imaging or coronary CTA is quite reasonable because that allows you to assess the ischemic burden and make judgments based on that. And then high-risk, stable women, stress imaging is appropriate, but always with concern for ionizing radiation. This is the graph. Essentially, I've summarized it. And the take-home points: low-risk symptomatic women, no need for diagnostic testing. Exercise, ECG, the initial strategy. Again, for the intermediate risk, prefer echocardiography or magnetic resonance imaging to limit the radiation exposure. But coronary CTA is reasonable for women who are at intermediate risk because you get information on the burden of obstructive CAD. And the risk stratification is based on the extent and severity of the inducible abnormalities. We've gone through a lot of territory, and let me try to summarize for you what I think is the prudent approach. The 2011 Women's Prevention Guideline is outdated in some areas, but certainly not in all. And I think use them, as I have shown you, where it is applicable. I think we have to replace or modify the outdated recommendations for cardiovascular risk assessment, for some lifestyle management, for treatment of blood cholesterol, and certainly with the non-invasive testing for suspected ischemic heart disease. Treatment of hypertension, your guess is as good as mine. I expect when we see some of the SPRINT data, it will help. There is a panel looking at the information now. It was thought they would have a recommendation out before the American Heart Association meeting next month. Perhaps SPRINT has put a kink in those plans. I don't know, that they work quite in secret. But I think we should add new information on the prevention of stroke and depression as a risk factor, and stay vigilant for the guidelines. But when you do that, see who was included. How does it relate to the woman sitting across the desk from you? And how can we best answer her questions? And I thank you for your attention.
Thank you very much, Dr. Wenger, for this excellent presentation. Any questions?
Excellent talk as always. You took a confusing subject and made it very clear to all of us. My question is, how do you deal with a very busy woman executive who comes in and says, I cannot meet the recreational exercise, but I do all this obligatory exercise. I'm exercising, walking up and down halls and all doing my work. You let her get away with that, or you say, no, you got to do something else?
How many of you wear a Fitbit at work? How many of you at work get your 10,000 steps? 2 of you walk more than most of us do, because I think that what happens is so much of the walking that many professionals do, you're thinking more of the standing time. So much of that time is standing rather than walking. And if during your workday you get your 10,000 steps, that's fine. But most people do not. And I suggest that anyone who is an executive has someone keeping her or his schedule in the exercise time. It becomes a very important part of what you do. And once it becomes an enjoyable and valued behavior, then it will continue. But the trick is to find out what you enjoy. And it may be, walking may be the easiest. A lot of people find the time getting to and from a gym is an inordinate amount of time for the time they exercise. But many people enjoy the gym. They enjoy the camaraderie. Find what you enjoy and do the exercise. But the 10,000 steps is really, to me, a benchmark. Arshad.
So, Nanette, thank you very much. I had a question about the recommendation in your piece about stress testing for intermediate risk women. Compared to calcium scoring, why would you now recommend stress testing, which is expensive, often leads to false positive results and catheterizations, and there is really little evidence that revascularizing these people improves prognosis? So why is that still in the guidelines, or is there data against what I'm saying?
Well, again, the data on coronary calcium are still emerging. A lot of it depends on the way it's determined. I think just the screening for coronary calcium tells you only that there's atherosclerosis. Coronary CTA, very different. It tells you the calcium and it tells you the obstructive burden. But just the presence of coronary calcium does not tell you about obstructive disease. The other advantage of stress testing is that you can detect myocardial ischemia that is not related to obstructive disease in the epicardial coronary arteries. And this is all the data from the WISE study and other studies that show that myocardial ischemia, documented, even absent obstructive disease in the epicardial coronary arteries, is associated with adverse clinical outcomes. So the detection of myocardial ischemia is quite important for women because myocardial ischemia kills.
Do you ever order only calcium score for the women?
Well, this is a challenge because that is not reimbursed by virtually any of our insurers, but so many women have their tests done by these mobile vans and come to you with a calcium score. To me, that means atherosclerosis. It does not tell me the extent of obstruction. It does not tell me whether there is myocardial ischemia. So it depends symptomatic or not. Larry. This is our real expert.
Let's see if this works. That one doesn't work. Okay, thank you, Nanette. That was wonderful. A great summary telling us where we are and maybe where we're going. Can you comment on your thoughts about whether the metabolic syndrome should be a concept that we have in our guidelines? What's interesting to me is that in our previous set of guidelines, there was a highlight for the metabolic syndrome, and then in the most recent prevention guidelines, if you look at every single word in every single document, there's never mention of the metabolic syndrome. And if you look at women, the paradox that older women are maybe doing better, but younger women are having more events, and a lot of that is related to the metabolic syndrome. Should that be something we reinvigorate?
Well, the concern I have with metabolic syndrome is that metabolic syndrome with diabetes and metabolic syndrome absent diabetes seems to impart different risk. And rather than clumping them, because you don't do one sole intervention for metabolic syndrome, I'm one that likes to split with this and look at the individual components, see how they impart risk. I would have no problems with summing them, but the intervention is for the individual components. And I don't say to a woman, you treat your metabolic syndrome with this. I look at the individual components, and that is my rationale for the splitting. All right, just remember some of these things when you go to clinic this morning and this afternoon, and I thank you for your attention.
The preceding program is copyrighted by Emory University.